Give it 1 minute and we'll get going. One minute. We'll get going. Alrighty, this is Holter tracing from a 15-year-old with an irregular heartbeat. Tracing was obtained at 3:30 in the morning. And just reviewing little repetition here. So what is the rhythm? What's the evaluation? What's the management? Why don't we ask Dr. Kalis what she thinks?
Good morning, Dr. Ross.
Good morning, Maya.
So it looks like we're starting off with a sinus beat. And then after the first one, I see wide complex QRSs. There is a P wave before the second one, but it's a shorter PR. And so it looks like it's an accelerated ventricular rhythm.
Mm-hmm. Okay. I would agree with that statement. So again, even though we see the P wave here, right, this is not conducting to the QRS. This is just a isosynchronous beating of the sinus node and the ectopic beat in the ventricle. So how would you evaluate this, Maya, or think about this?
Well, I'd have to kind of caliper it out to see like exactly how fast it is, but it doesn't look like it's extremely fast.
Let's say
Like it'd be like a tachycardia.
for the sake of this conversation, let's say it's at like 70 beats per minute.
Okay, and then
And
the
the
sinus.
sinus beats are 69 beats per minute.
Okay, so it's like almost at the same. So it's a little bit faster than the sinus. And so it could be this is at 3:30 in the morning and the patient is sleeping. That if the patient has like sinus node slowing or something, this could be like a ventricular escape for them.
Mm-hmm. And is this is this normal, abnormal? Are there any actionable steps that one needs to take if you see this?
I mean, it's a little bit faster of a escape rhythm than I would expect, but if it's just at this rate and when the patient is sleeping and has a slow sinus node, I don't think it would be necessarily problematic.
Right. So I think this would sort of fall into the category of maybe abnormal but not dangerous. And so we would normally just observe something like this, see how much of it the patient's having, see if the patient is symptomatic from this. Presumably at 3:30 in the morning, the patient did not feel this. But these types of accelerated ventricular rhythms, they do come up. We do see them sometimes, not infrequently on Holters or Zeo patches. Can see them in the ICU overnight, sometimes in some patients. But generally speaking, they are largely benign, particularly when they're this slow and in a very similar rate to the sinus rate. I don't know why someone would have this rhythm being, as fast as 70 beats per minute. But what we would normally do is you'd scan the rest of the Zeo to see if there's any more of this, if there's a lot of this, if there's ventricular ectopy. You'd want to ask the patient if they're feeling palpitations at any time, because the only time we would ever consider treating what would be the indications to treat ventricular ectopy, Maya? So let's say somebody comes into the office and they have, unifocal PVCs. You have two of them on your resting surface ECG in the office. you do a ZO, and let's say that, or a Holter, let's say that this Holter shows that the patient has 7% PVCs, and that this is just, the longest run of it. There were no other runs of PVCs, but that's 7% of all the QRS complexes are PVCs. So, um, you call the mother of the patient to tell them that what you found. They say, well, doctor, that sounds abnormal. 7% are these unusual beats. What would you do about this? And how do you decide if you need to do something about this in general, PVCs?
So it's not, I mean, it is abnormal to have 7% PVCs.
Hmm.
However, I think usually kids are generally okay and asymptomatic at 7%. I think I
Okay.
would still monitor like every few years, get a ZO, and also get an echo and kind of monitor the patient's symptoms. And I think indications for treatment would be if there's any sign of dysfunction on the echo, or if there's any symptoms.
Right. So that's exactly right. So you would treat basically either if the patient was symptomatic, and you have to confirm, of course, that the symptoms are related to the beats. Very often, patients have symptoms, but when you look at the time that they press the trigger button on the ZO or in their diary, oftentimes they don't correlate to the PVCs. And someone who has 7% PVCs basically should be pressing the button continuously all day if those are what's causing their symptoms. So, okay, so, and you said you would get an echo to look for dysfunction. So, do you have any sense of how many PVCs you would need to start to see dysfunction or dilation of the heart related to PVCs?
I think in kids, it's up to like 30%.
Actually, I don't think there's any definitive number, to be honest with you, in children. I've seen children with even 50% PVCs who don't seem to have dysfunction. In the adult world, however, it is not uncommon. I think the number that's quoted often is 20%. I think there are large-scale studies in adults that once the PVC burden exceeds 20%, the chances of developing a tachycardia or a PVC-induced cardiomyopathy start to rise. And so that is often used as a line in the sand in the adult world for consideration of either medical or transcatheter therapy for ventricular ectopy. Just just a few in the last few weeks, I saw a patient as a second opinion who was in their early 20s and who was seen by an adult electrophysiologist, and she had 23% PVCs. Um, Interestingly enough, she was symptomatic in that she had had a number of episodes of syncope, but the syncope was very typical neurocardiogenic syncope, things like standing up from a seated position, immediately after urinating, things of this nature. Um, and um, and so the adult doctor who they had seen, electrophysiologist at a major center not named Mount Sinai, was recommending an ablation of the PVCs because they were in their 20s and they were having PVCs, and they wanted to know what I thought about it. And I actually said, well, what would you have said, Maya, if you, based on what we've discussed? This young lady is basically largely asymptomatic. I mean, is having symptoms, but it seems quite clearly unrelated to the PVCs. There's 22%. Anything you want to know about the patient or?
I guess in terms of other things to know, um, I guess you talked about if she's having symptoms or not. Like I would also just
So
kind of
doesn't
ask.
seem like the symptoms are related to the PVCs. Now, you
Mhm.
just on this case, you said you would get an echo. Would you want to get an echo
Yeah,
in that patient?
yeah.
So the echo showed an ejection fraction of 53% with normal dimensions.
Okay.
So you're being asked, as the electrophysiologist, second opinion, Do you agree, Dr. Kalis, with this very aggressive adult electrophysiologist's impression that this should be ablated?
Um, I think with kind of borderline low EF like that, even if her symptoms are not really related, I don't think it's unreasonable to go ahead and treat that.
Yeah, and that's basically exactly what I said. I told the family that they were in very good hands. Adult electrophysiologists do a lot of PVC ablations as well. Probably that's one of the areas where, like a fib, they do more of them even than we do in pediatrics. And I thought that the combination of sort of a low normal ejection fraction in concert with a burden of PVCs that exceeded 20% was a very reasonable indication in a young person to proceed with an ablation. And I said it in a very similar fashion to just how you did, Maya, which is I said it was not unreasonable and probably a good idea. I explained that it was not an urgent matter, but that the general recommendations. Another option would be to sort of follow this, maybe keep an eye on the ZOs or Holters and see what the burden of PVCs are. It's very interesting to see that people with PVCs can really go from having a very high burden on one tracing to having a much lower burden on another tracing. And so, one of the good rules of thumb when you're following someone with PVCs is it's not uncommon that you do a Holter or a ZO and you have, say, 30% PVCs, you're very concerned. And then like 6 months later, you repeat it and it's 2%. And you get very excited that it's so much better, but it's always worth to confirm and repeat because it does seem like these can come and go a little bit. But yeah, I mean, that would not be unreasonable to wait, but my attitude was, is really, as I explained to the patient, she's only going to be a less good candidate for ablation as she gets older. And, all of us, any surgical procedure, interventional procedure is going to be safer when you're younger and healthier. And with that burden of PVCs, I think the likelihood of developing dysfunction is not nothing. And we've already discussed it in adults. The 20% is sort of the line in the sand. And so I was supportive of that. Now, could one repeat a ZO and just see if that burden of PVCs was similar? Is it possible that ejection fraction has absolutely nothing to do with the PVCs? Absolutely possible. But I think it was a very reasonable approach. And so I believe the patient was going to proceed with the ablation at the other institution. All right. Any questions about any of that?
I did have a question.
Sure.
Would you routinely do stress tests on these patients to see if it
Ah,
suppresses?
that's a very good question. I think it would really depend on how much they have. If I had a patient who had let's say, excuse me just one moment. I apologize. I'm very sorry about that. So you were asking about whether I would do a stress test. So if I had a patient who had a ZO like this and they had this relatively low burden of PVCs, and it was just sort of at night, I probably would not do a stress test. But if someone had 7 or 8% PVCs, I think it would depend on how fast they are, but I probably would do one as a general rule. As you know, there is a general belief, certainly in the adult world, there's some literature to suggest that if you exercise and your adrenergic tone increases and the PVCs become suppressed by sinus, although you can't hang your hat on it, that is generally viewed as a very reassuring sign that the ectopy is not a dangerous form. Maya, what condition would we start to see more PVCs in with exercise?
You could see it in CPVT.
Right. So CPVT is sort of the classic example of a disease, of ventricular arrhythmia disease, where um, lots of PVCs can come out with exercise. In fact, the classic teaching for CPVT is that when the sinus rate starts to hit about 120 to 140, you should start seeing singles and then complex ectopy. And in my experience, which is limited in seeing this, but I have seen it a handful of times, usually it's very scary looking ectopy and you stop the test immediately. And And if it is CPVT, very often the arrhythmia will stop as soon as you stop exercising. So yeah, I don't think it's an unreasonable thing. Again, it depends on how much ectopy. If it's like 3 or 4%, it's not complex ectopy, meaning not seeing lots and lots of runs of it. Or fast runs, I would probably not do a stress test. But if I'm starting to see higher percentages, more complex runs, then yes, I would do a stress test to confirm that or to make me feel a little more confident or comfortable with the ectopy that I'm seeing. Any other questions about that? Okay. Alrighty. Uh, okay, so this is a very old freeze frame of an angio, and the catheters have been labeled in this case. And my question here is, where is the ablation catheter ablating, and how did it get there? So why don't we ask Dr. Khalif what he thinks?
Good morning, Dr. Bass.
Hey, Mohammed.
No, I don't want to.
Sorry, are you talking, Mohammed?
No, I'm just
Oh,
thinking
oh, oh,
as
okay.
so I'm thinking of push.
You're thinking so strongly that I could hear your thoughts.
That's how much I'm struggling.
That's
So
funny.
when is in the top RA, when is in the RV, and I think the his bundle, right? And then the
Right.
ablation is the one.
It's the one that's labeled ABL.
Yeah, so I'm
Yes.
thinking it's in the coronary sinus, but
So you're thinking it's in the coronary sinus? Is that what you're?
or around it.
Okay.
Or actually, I can think. I think it's in the RVOT maybe,
You think it's where? I'm sorry.
and the RVOT.
In the RVOT. Well, this is an LAO projection, and this is in the RV apex.
Okay, so it's
So in an LAO projection, right, the RV is sort of going to be on this side, and the rest of
okay.
the heart will sort of be on this side.
Mm, okay. Probably in the left atrium then.
Left
Or it's
atrium, did you say? First of all, what do you think is the catheter course? So just so we see it's cut off because someone is practicing good radiation safety here, but it seems as if there seems to be a catheter along the left side of the spine. It disappears out of the frame, but maybe is coming back over here.
okay. So it's probably the left ventricle.
Yeah, this is how we would normally ablate ventricular tachycardia coming from the left ventricle. It's usually done retrograde. And part of the reason for that is because a lot of these foci that we take care of in children that are on the left ventricle are arising from the left ventricular septal surface. And so it's actually easier to manipulate the catheter along the LV septum coming retrograde this way. I remember one time I was having difficulty getting to an area and I went transeptal and passed the ablation catheter into the LV across the mitral valve. I was able to successfully ablate it, but interestingly, I created a tiny hole in the mitral valve leaflet, and the patient left the hospital with trivial MR through a catheter-induced hole. I was pretty upset about that, obviously. So I always think about that when I'm passing it in, but this is now, I guess you could have imagined that this was coming down if you didn't notice this, and there's no real way to know that this catheter here is attached to this line here, but could have been coming down from the IJ. And if you had said that I was ablating something here in the mouth of the coronary sinus, it's not impossible to imagine that it could be coming down from above into there. It would be an unusual way to ablate something there. The only time I've ever done that is in something is in the middle cardiac vein, because the middle cardiac vein. So in this projection, right, the coronary sinus would be sort of over here somewhere. And sometimes the middle cardiac vein, as you know, is like a little outpouching of the coronary sinus, and it can be challenging coming up from below to get the catheter go in the CS and then go down into this little pocket where the middle cardiac vein is. So on rare occasions, I've from the IJ been able to sort of get the catheter jam it back better into the middle cardiac vein for accessory pathways that might be available there. But in this case, I think this is so leftward that this is an example. And what would the most common LVVT or PVCs be? What would we call that if we're doing LV outflow PVCs? Mohammed.
I think it would be a superior access, right?
Yeah, and so we would call it, it's usually if it's an LV outflow or posterior fascicular VT, we would call that, that's the other name for that, is Bell-Hassen's ventricular tachycardia. And so this is a typical location or manner in which we would ablate someone who's having PVCs from the LV outflow tract, which is a common location in children when they have, PVCs that need to be ablated. One of the very first ablations I ever did as an attending physician was a 4 or 5-year-old girl who was having, like 60% PVC burden. And I would remind that this was in an era before we had Carto or 3D mapping. So we just sort of would go in and just do traditional mapping and timing. And I used a 5 French ablation catheter, which still exists, but is rarely used. And I, remember that the His is on this side, is right here. And so the conduction system is here. So one needs to be very careful when you're ablating in this region that you don't get heart block. And I remember that we found a spot that was very early. We thought it was not on the His. I turned on RF current. And on the 4th or 5th beat, the patient started having junctional tachycardia, suggesting that I was heating up the His bundle. So we immediately turned off the RF. So we only gave about 4 seconds. And thankfully, the patient did not get heart block and never had PVCs again. And that actually highlights one of the theoretical benefits of ablating smaller children, which is some people believe that less RF is necessary because the foci are smaller and the catheter size is relatively large. There's lots of pros and cons to that. But anyway, bottom line is this catheter is in the LV. I apologize, but I'm going to have to stop a little bit early today, but I appreciate you joining. Any questions about any of that? Okay. All right. Thanks, everybody. I hope we'll have a good day today.
Thank you.
Thank you very much.